Good afternoon, and thank you for joining us for day 3 of Lipid Palooza, hosted by the National Lipid Association in celebration of National Cholesterol Education Month. My name is Eugenia Gianos, and I'm an associate professor of cardiology at Lenox Hill Hospital. I'll serve as the moderator for this session. I'm joined today by Dr. Robert Rosenson, who's a professor of medicine at the Icahn School of Medicine at Mount Sinai, and he'll be presenting a special lecture on what's new in HDL function testing. If you have any questions for us during this webinar, please send them in to us in the Q&A section. You can see it's at the upper right-hand side of your, in the corner of your screen. Just type in those questions. We'll be collecting them. We'll try to get to as many of them as we can at the end of the session. It is now my pleasure to welcome you to the virtual stage, Dr. Rosenson.
Hey, good afternoon, everybody, and thank you very much for the invitation. What I'd like to do is discuss what's new in HDL function testing. These are my disclosures. HDL is comprised of multiple subspecies that are often characterized based on their size, but also on the major protein composition, such as whether they have apolipoprotein A1, A1A2, or ApoE. Another way that we characterize the HDL particle is based on its shape, a discoidal particle or a spherical particle. Multiple advances in this field allow for even more categorization of HDL subspecies based on their major protein components, in addition to A1, A1A2, and E, as well as the different lipid species. So HDL subspeciation has emerged as a very important area for characterizing structural and potentially functional aspects of the HDL particle. We had the opportunity with an HDL working group to bring the major leaders in different analytical methods together to define a classification system for HDL based on physical properties. We characterize these different HDL particle sizes into the categories of very large, large, medium, small, and very small HDL particles. And the value of this table is that you can compare the different methods that are used by investigators and see how that method compares with another method when you're trying to understand the terminology used in the peer-reviewed publications. What's not adequately captured in this table is the pre-beta HDL, or the discoidal HDL, which is a very important HDL particle that I will talk about. This is a very busy slide, and the purpose is not to read the details, but this is a table from an upcoming chapter in Hurst's The Heart, Dyslipidemia, that I'm leading this chapter in collaboration with some other world-class investigators in this field. And what this table shows is that HDL particle concentration, reflecting the total number of HDL particles, regardless of their size, is a better biomarker of risk than is the cholesterol carried in the HDL particle. And most studies show it's better than apolipoprotein A1. Of course, apolipoprotein A1 varies based on the size of the HDL particle, with either 2 to 5 apolipoprotein A1s per HDL particle. So it's variable and highly correlated with the size of the HDL particle. Using the NMR methodology to quantify HDL particle concentration, and certainly there are other methods that have been developed, such as ion mobility. But using the NMR measurement, you can actually detect glyc-A, which is a sialic acid residue that binds to the HDL particles. And in this analysis from the Dallas Heart Study, we can see that after adjustment for major risk factors, that the risk of atherosclerotic cardiovascular disease events increases 3.33-fold. And after including macrophage cholesterol efflux by the Bodipi assay into the model, the risks associated with glyc-A remain elevated. Similarly, similar relationships seen for total cardiovascular disease events. So what this data suggests is that although we think about HDL particle concentration as a static measure, that there are some pro-inflammatory effects that can be detected with the glyc-A on certain HDL subclasses. And those two measures together importantly relate to cardiovascular risk, even after including another major HDL functional metric, the Efflux assay. Now, the major functional aspects of HDL include the macrophage cholesterol efflux, antioxidant effects, anti-inflammatory effects, protection against endothelial dysfunction, and glucose homeostasis. The terminology of reverse cholesterol transport was promulgated by Glomset and incorporates the cholesterol efflux from the macrophage to its ultimate disposition in the feces. So there are multiple steps involved in reverse cholesterol transport. The macrophage-specific arterial wall efflux, non-macrophage arterial wall efflux, non-arterial wall efflux, lipoprotein transport, hepatobiliary excretion, and fecal excretion. But what we can say is that HDL cholesterol is an inadequate surrogate for this functional property. All right. On this slide, we can see why I make that point. When we consider the amount of cholesterol transported in an HDL particle, less than 5% of that circulating HDL cholesterol derives from the macrophage. And from the macrophage, there are multiple cellular receptors involved in the efflux of cholesterol, the most important being ABCA1. And the reason I say the most important is because in models where you genetically delete ABCA1, you can't have efflux, whereas you delete ABCG1, you can, or you still have, delete ABCG1, you can still have efflux through the other pathway. So ABCA1 is the more important of the two pathways, but they're both important, and SRB1, of course, has other roles. So we have this discoidal HDL particle, these discs, that are better characterized as cholesterol absent, phospholipid depleted ApoA1 complexes. That's the precise terminology. So when cholesterol comes out of the macrophage, interacts with these ApoA1 phospholipid depleted cholesterol absent discs, you get a spherical particle. But the point is, less than 5% of the circulating HDL cholesterol comes from the macrophage. Other parts of the HDL cholesterol pool are coming from the liver, 75%, and 20% from the intestine. Now, there have been several investigators who have evaluated the contribution of cholesterol transported by HDL from multiple sites using multicompartmental modeling. In the most recent paper, is one that was led by Marina Kutchel from University of Pennsylvania. And basically what they're doing is that they're sampling different blood components and also looking at different cells, looking at fecal excretion for labeled cholesterol to try and understand where the cholesterol is derived. And they're able to provide important data that's based on the macrophage free cholesterol to HDL free cholesterol, that fractional transfer, the number of pools, the free cholesterol to non-HDL cholesterol, to the cholesterol ester, and then the transport amongst other lipoproteins. And that type of an approach, which is a very time-consuming, expensive, but detailed approach, gives us an idea about where that cholesterol is coming from. But most of the work in this field is involved the macrophage. Of course, we're concerned about atherosclerotic cardiovascular risk. And before I discuss those methods in more detail, it's just to remind you that there are different cellular receptors on the macrophage that are involved in efflux, ABCA1, ABCG1, SRB1, and of course there's passive diffusion. Do not forget about apolipoprotein E, which is important in brain homeostasis. ApoA1 is not involved in cholesterol metabolism, efflux in the brain. So different ligands, different HDL particles, different receptors. So how do we translate this information? There have been three methods that have been evaluated. The efflux of tritiated cholesterol from J774 macrophages, efflux from the RAW264.7 macrophages, and a fluorescent, so therefore a radio-labeled method, Bodipi cholesterol. The pioneering work from George Rothblatt, Adorni, Dan Rader, Marina Kutchel, Delera Moya have used cholesterol loading of macrophages, and they inhibit the cholesterol efflux by using an ACAT inhibitor. So they're radiolabeling the cholesterol to load up the cells, preventing the efflux with an ACAT inhibitor. And then they're giving cyclic AMP to upregulate ABCA1, and then they're incubating these cells, exposing them to the HDL particle from ApoB depleted serum. And then they're looking at the amount of cholesterol coming out of those cells, which is a percentage free cholesterol efflux. In the study led by Delera Moya, we can see that cyclic AMP increases predominantly the ABCA1 mediated efflux, decreases SRB1, so more coming from ABCA1, no effect on diffusion, and maybe a minor effect on ABCG1. And that's why they use, cyclic AMP. In this very important study, a cross-sectional study led by Mitkara, senior author Dan Rader, they show that cholesterol efflux capacity is inversely related to the risk of coronary disease with an odds ratio of 0.75, a significant association here. The other method that's been evaluated is the boron dipyromethane difluoride, or Bodipi assay, developed again by George Rothblatt. Again, you're taking the J774 cells, you're labeling the cells with Bodipi, the boron, you're inhibiting the efflux with ACAT, you're upregulating the predominantly ABCA1 transporter with CMP, and then you're looking at the amount of fluorescence coming out of the media as a measure of percent cholesterol efflux. The two methods were compared in the study by Adorni. back in 2007 in the JLR, showing that ABCA1 efflux can be detected by both of these methods, incubating with HDL3, increase efflux, and then also with 2% PEG. Comparing Bodipia against tritiated cholesterol efflux, Bodipia has a larger response and with the effects of ApoA1, a larger effect in terms of PEG, and the two methods are correlated with an R-square of 0.69. In terms of the association with the pre-beta HDL, those ApoA1 complexes, the Bodipia assay shows a higher correlation, 0.58, than the tritiated method here. And the cholesterol association is less with Bodipia, so more independence, than it is with the tritiated HDL method in this study. Now, there are certain functional alterations in the ApoA1 that can influence efflux, and I'll delve into this more when I talk about dysfunctional HDL. But there may be people that have systemic inflammation, not just bacterial, but could be viral, where there's myeloperoxidase that can modify the HDL particle, result in chemical modification that impairs efflux, and that can be associated with a higher event rate, as shown in this cross-sectional study by Shao from the Heineke laboratory. In this table, we can see that modification of the ApoA1 with methionine at the methionine 148 residue. I'm sorry, these lines should be up just a little bit. So it's with a higher risk of coronary disease, as is a modification from 3-chlorotyrosine. Plasma myeloperoxidase, which some people think they can measure for HDL functional properties, is not associated in this study. Inverse relationship between HDL cholesterol and events and ABCA1 efflux capacity, as shown in the last line. In this study from the Dallas Heart Study, they used Bodipia method that more efflux, lower event rate, and in the bottom part here we can see the adjusted analysis for traditional risk factors. Hazard ratio 0.30, including HDL cholesterol remained significant of the same magnitude, and the same for adjusting for HDL particle concentration. So this is a functional method that provides incremental information about risk beyond HDL cholesterol and beyond HDL particle concentration. In this very busy slide, it's basically showing that the more efflux, the lower the risk, and looking at this quartile analysis, less efflux, higher risk for atherosclerotic cardiovascular disease and total cardiovascular events. This analysis shows that although HDL particle concentration is also a significant predictor of reduced cardiovascular risk, the higher the HDL particle concentration, that even adjusting for HDL particle concentration, one learns something about efflux, as shown in the Dallas Heart Study. And this is just showing correlations between efflux and other lipid lipoproteins. And although the association between HDL cholesterol was 0.07, it was more with HDL particle concentration 0.15. But again, those are very low, R values. supporting the importance of this measure on cardiovascular events. This slide breaks down the different endpoints. We see the adjusted hazard ratio. We discussed 0.33 for total cardiovascular events, and it remains significant for the different components of the cardiovascular events, including myocardial infarction, well, it tended to be significant, 0.44, stroke, 0.11, revascularization, 0.19, although death for cardiovascular disease was not associated in this study. Another study that was presented at the same time and published in Lancet Diabetes and Endocrinology was a nested case-controlled study from Epic Norfolk, and they looked at efflux capacity in 1895 subjects with coronary heart disease and control participants. And this study used the radio-labeled method for cholesterol efflux that was used by CARA in that New England Journal of Medicine paper. And in this study, we can see that the risk of cardiovascular events were lower with more efflux, and that remained significant. After multivariate adjustments, there was some attenuation, including HDL cholesterol into the model or apolipoprotein A1, but efflux still remains significantly associated with a lower risk for cardiovascular disease. Now, there are other measures that have been less well validated, but may be important, emerging area. And what we proposed in one of our international collaborations is that we have markers of HDL functionality, but we have to validate them with an atherosclerosis measure or validate them with a measure of cardiovascular events. In other words, developing an assay for a functional property without showing its association with atherosclerosis and or cardiovascular disease, is not adequate. We know that HDL and partly through the role of ABCG1 is involved in monocytosis, and the pioneering work of Alan Tall, the longstanding work from his group, showing that HDL is involved in this pathway, and dysfunctional HDL may be characterized by high, total white blood cell count and higher concentrations of mononuclear cells. And he's identified, the target in the progenitor cells where this works, and the critical role of ABCG1 and also ABCA1 in this pathway. So in terms of dysfunctional HDL, I mentioned before that under situations of inflammation, where you've, particularly with myeloperoxidase, you get site-specific modification of ApoA1 certain residues. And this is work that was conducted, from Stan Hazen's lab, and then independently, and work from the Heineke laboratory. So there's multiple site-specific modifications. And these modifications can result in a dysfunctional HDL that results in not an anti-inflammatory effect for HDL, but actually a pro-inflammatory effect, activation of nuclear factor kappa B, as shown over here. But as I mentioned in an earlier slide, this dysfunctional HDL, particularly ApoA1, can interfere with macrophage cholesterol efflux. Concerning events, if you've got these site-specific modifications, we can see that there's more of this dysfunctional HDL in the atheroma of people with coronary disease, a signal that is not seen with HDL cholesterol and ApoA1. And I mentioned that earlier that in that case control study by Shao Heineke, more cardiovascular events and an ACS population. So to summarize, HDL functional considerations involve understanding HDL particle concentrations, the types of particles. And I think that when you evaluate studies, publications of HDL functional measures, adjusting for the amount of cholesterol in the HDL is inadequate. Adjusting for the amount of ApoA1 is inadequate because there's variable amounts of ApoA1 per HDL particle. We feel that adjusting for HDL particle concentration, either by NMR, ion mobility, is what needs to be done. So you need to express the function based on a denominator. And again, the data that we have with cholesterol efflux show independent contribution in large studies after an adjustment for HDL particle concentration. Of the HDL functional measures, the efflux assay by either the radio-labeled cholesterol or the Bodipi assay have both been shown to be related to cardiovascular events in large studies, and therefore they have the validation. We also know that there's certain HDL functional measures, include antioxidant and anti-inflammatory effects, a functional measure developed by the UCLA group, the monocyte chemotactic assay, but very labor intensive. And then there's other method that has been evaluated to look at a marker of oxidation of ApoA1. So this is an area that I feel is still emerging, and where is it going? We now have the ability to measure not only major proteins on HDL, but minor proteins, the HDL proteome. And the HDL is very rich in proteins that have functional properties. The HDL particle is also very rich in lipids. Would that also influence HDL function? And I know that there are ongoing studies. We have a NIH funded study in R01 looking at HDL proteins on incident Alzheimer's disease. And in that study, we will be adjusting for HDL particle concentration. I know that there's another NIH-sponsored study looking at HDL proteome and the risk of atherosclerotic cardiovascular events. So that, I think, is where the field is going, is to be able to do a high throughput assay measuring specific proteins and lipids that have been validated in larger studies, markers that have functional properties. So at this point, I'm going to stop and be very happy to take questions after the that you submit. Thank you.
Great. Thank you, Dr. Rosenson. That was wonderful. I'm going to open this up to questions, and I will start. Certainly that was a lot of information. The future in terms of what we're understanding about HDL. And for our audience to sort of bring it back to the current time and clinical practice and what we actually can do with this information, I'm curious as to your thoughts. Most of the time when we see, abnormalities in HDL, lower HDL levels, they come coupled with, mildly elevated triglycerides, perhaps a metabolic, kind of picture. But, outside of, starting with LDL and non-HDL as a target, assuming your other numbers are at goal, how do you factor in somebody who does have a low HDL? Is there anything different that you do clinically at the present time?
Yeah, so the clinical trials in individuals with low HDL cholesterol, or even people with normal HDL cholesterol levels, have focused on loading up that HDL particle with more cholesterol. And we've learned that by doing so, you can create a particle that loses its antioxidant, anti-inflammatory, anti-apoptotic, and probably antithrombotic properties. And that's because as you load up the cholesterol particle, you're shedding some of these very important proteins. So the analogy would be a painted balloon. You blow it up, and what happens? The paint cracks, all right? But because all the strategies published to date have focused on cholesterol loading, we really don't know how to modify the HDL particle in a way to maintain efflux and antioxidant anti-inflammatory effects. There are studies that are ongoing, post-ACS population, that are using a synthetic, pre-beta HDL particle. So the first study that was conducted with that approach, they used too much phospholipid on the ApoA1, and they didn't get the efflux that they expected. So now with a phospholipid depleted, cholesterol absent ApoA1 moiety, we've got a trial underway in the post-ACS population. We also are aware that if we delipidate HDL and give back these nascent HDL particles back to the patient, that we can actually decrease the amount of atherosclerosis in the carotid arteries and the coronary arteries of those individuals. That technique developed by Brian Brewer. So that's what we have. What do we do clinically? Well, what we do clinically is we focus on a healthy lifestyle, because HDL cholesterol is a marker of bad health. In other words, the studies have shown that people with the lowest HDL cholesterol levels tend to be more overweight, more sedentary, smoke, be exposed to passive smoking, more likely to have diabetes, all right? Higher HDL cholesterol levels are associated with a healthier lifestyle. If the HDL particle concentration is low, we have got data from Kraus, K-R-A-U-S, from Duke, not Ron Kraus, but a different Kraus, in the STRIDE trial, showing that high intensity, high impact exercise can increase HDL particle concentration. So that's what works in terms of the HDL space.
Great. That's wonderful. Yeah, I'm fascinated by the various things that you mentioned that can affect HDL. I think we've historically known exercise, of course, and potentially obesity can lower it. High carb diet can lower it. But all the inflammation, diabetes, all the factors that really do influence HDL is really quite interesting and important to make sure we focus on those. A number of the questions are actually about how else we test, whether it's worth doing HDL particle number, functionality testing in the clinical realm, basically to get to the reverse cholesterol transport and how effective it is. Are there any of these that you think at the present time are relevant to our clinical care?
Yeah, other than HDL particle concentration, maybe the glycate HDL, index, something that's clinically available. Again, 2 methods, multiple laboratories. So that's available. We know that, and I didn't go through the data in great detail, but you can have people with high HDL cholesterol have low HDL particle concentration, they have more atherosclerosis, higher events. You can have people with low HDL cholesterol who have high HDL particles and not be at increased risk for cardiovascular events. So HDL particle concentration is a better marker. This is what we're using in our, our NIH study, in Alzheimer's, the ion mobility developed by Jay Heineke, but other methods are available, NMR. In terms of these functional assays, it's, what are we going to do about it other than the lifestyle changes that we talked about? We, need to wait, for the outcome study, with the ApoA1, complex, to be able to know whether, we learn anything more by looking at certain functional properties than we do by evaluating HDL particle concentration. Similarly, in terms of the delipidation, that offers another opportunity. But we've got to, within these studies, compare different HDL measures against each other and know, whether it provides, again, incremental information beyond the HDL particle concentration, or not. So the way I look at these studies is that they're really supportive of a certain mechanism with a certain intervention, and hopefully gives us more confidence to move forward in terms of phase 2, phase 3 studies. But I don't know that for clinical use, this is what we would recommend, today. I really think that the field is moving into, very detailed measures of HDL proteomics, lipidomics, where these multiple subspecies of, HDL particles, can be tied to a certain function, and then you would be able to figure out those patterns. And it's a less expensive and more robust approach. And of course, I would be remiss not to explain the pioneering work of, Frank Sachs and his group, where they've, looked at, the ApoC3 on HDL, which is, creating a dysfunctional type of HDL, or one that's associated with, less cardioprotection. So, looking at even ApoC3, which can be measured, but it's got to be on the HDL particle, not free circulating ApoC3, which, you can measure in the laboratory.